Thanks to the organisers again for giving me this opportunity to present a second talk on next generation risk stratification. We had some excellent conversations yesterday about screening and diagnosis. Here I'm focusing particularly on the post-diagnostic space. But first, briefly, some declarations. I run a lab trying to come up with better ways of understanding prostate cancer, specifically identifying lethal disease. Our funding depends on this and in part on my persuading people that we don't do it very well currently. In addition, like many of us, I guess, any talk or piece of writing I do may help my chances of visibility to potential private patients. So again, I hope that you will filter anything I'm saying through those lenses. And again, I have a personal interest in this too. So we're going to look at what I think are the three big questions in prostate cancer: tumor heterogeneity, metastatic disease as a window into meaningful disease, and the future of risk stratification. So by way of background, I guess I wanted to quickly start with a reminder of what I think at least are the three big questions in prostate cancer: who to investigate, who to treat, and how to keep treating advanced disease, otherwise known as screening, risk stratification, and therapy for treatment-resistant disease. Most research efforts, biologically at least, have focused on this third question with great success over the past 10 years, such that we can essentially consider prostate cancer now to be a chronic disease. And with this success has flowed the research dollars. But actually, the majority of men diagnosed each year with prostate cancer are not in that green circle, but they're in the middle, the red group. These proportions shown are for the UK. And if we consider screening, then of course the numbers and potential impact are huge. So as a surgeon clinician scientist, I've intentionally positioned my lab's work here in the red circle. But my hope is that anything we discover in this space would potentially be useful to the large numbers of men that will be diagnosed with prostate cancer through screening. That's potentially up to 5 million if we consider men over the age of 50 in the United Kingdom. Another way to come at this problem is to look at the Prostate trial, which reported its 15-year outcomes the year before last. I think we were perhaps all a little shocked that at 15 years, there was still no difference in disease-specific mortality, whether or not men were treated at diagnosis. And before the doubters shout out, it's important to remember that this was our patient group. 2/3 had intermediate or high-risk disease, and 30% had PT3A at surgical pathology for those that had prostatectomy. But actually, I think the key figure is this one. To get this equivalence, 60% of men on active surveillance did have treatment at some point. Most men can have surveillance at the start, but some do still need treatment. We need to get better at finding those men. Either way, with the screening trials coming over the horizon, we're going to have many more men being diagnosed with prostate cancer, many of whom, of course, won't need treatment. So we've got to get this right. So what's behind the big questions in prostate cancer? We had to pick one thing. Many of us would say it's intratumoral heterogeneity. As everyone listening knows, for decades, we have risk stratified prostate cancer using a combination of three things: a non-invasive biomarker, PSA, which we get from a blood test, TNN staging from examination and imaging, and histological grading from prostate biopsy, the Gleason score. Still one of our most accurate predictors of outcome. But there are big inconsistencies here, with lots of crossover between groups in terms of the risk of life-limiting disease. And some men we expect to do well, doing poorly, and vice versa. Using high-resolution spatial transcriptomics, we've been able to map clones in prostates from radical prostatectomy. And this is a slide that I shared briefly yesterday. We showed that within a biopsy, there can be multiple clones, each with a quite distinct expression profile. And that therefore we need to be much more intelligent about how we use the information available to us in histology at biopsy. As mentioned, prostate cancer is a fundamentally heterogeneous and multifocal disease. Within the prostate on the left of this diagram, the surgical space, if you like, and then systemically on the right, the medical oncology space. Our objective, and that of many working in cancer evolutionary biology, is using all the sampling methods available to us to unpack the spatial heterogeneity in intraprostatic disease and to identify the origin of lethal extraprostatic disease so that we can throw the kitchen sink at it before it becomes incurable. and then de-escalate everyone else. Looking at this clonal expansion or fishtail map, we see our goal more clearly: to precisely identify lethal subclones responsible for spread and treatment resistance and ultimately death from prostate cancer. In other words, to identify the orange clone here in the prostate, which gives rise to the purple and red clones systemically. We need to know about this if we're considering whether or not to perform radical therapy, and if so, the possibility of multimodal approaches. But if the orange isn't present, then do we even need to treat? So how are we going to get answers to this? As mentioned, this is what my lab does. And we use nodal mets, particularly at surgery, as a window into lethality. So metastases as a window into lethality. This is what we call our organ scale nodes program. As you can imagine, it's important to have a robust workflow starting in the operating theatre. And from there to pathology cut-up, we made a little video here showing how we do all this for anyone interested. Very briefly, the data I'm going to share rests on some work we published a couple of years back using spatial transcriptomics to create high-resolution clonal map of prostates and selected other tissues as well in this paper. The beauty of this approach is that it allows us to observe the whole transcriptome at near cellular level to infer underlying genomic copy number status. And because the tissue is intact, all of this can then be underpinned by very detailed consensus pathology calls. A key part of this is tissue preparation. One of the exciting things about the newer Visium chemistry, the 10x Genomics platform that we use, is that they work really nicely on fixed tissue so that we can open up the archive rather than having to freeze tissue in advance. Tinesh Ambarasan has again prepared a nice video of how we do this, which you can find from that QR code. Here's a summary from one patient of how we now approach our pipeline. With the various sampling points available, we obtain diagnostic biopsies, prostatectomy and nodal metastatic tissue reflective of the spectrum of heterogeneous local and early metastatic disease, alongside information about subsequent disease progression. Using the computational approaches that I've touched on a moment ago, we create a comprehensive phylogenetic clonal map based on inferred copy number alterations and use this to deduce tissue-wide clonal dynamics. With the power, for example, to determine where the ancestral metastasizing clone arises, tracking it through the prostate and into the lymph node, where, intriguingly in this patient, there is then further subclonal mutation and a second clone arriving from the prostate at a later time point. So what will risk stratification look like in the future? I finished with this in my talk yesterday, and we'll take the liberty of doing so again. We think it's critical to unpack clonal dynamics alongside the tumor microenvironment in the prostate. Here's a radical prostatectomy specimen, an axial cross-section through the middle with Gleason grade group 3, Gleason 4+3, distributed across the PZ and the right anterior horn. But as we see from the ST, from the spatial transcriptomics, it's actually made up of multiple clones. We add in the biopsies, and we can see that these biopsies picked up the green clone on the right and also the purple and orange clones on the left. We call these the X clones because these are the ones that have metastasized to the lymph nodes. And so now we see the possibility of differentiating those areas of Gleason pattern 4 that have the potential to metastasize and those that do not. Ideally, of course, we'd like to be able to detect these non-invasively, and an excellent PhD student of ours, Tinesh Ambarasan, is helping to develop deep learning models to enable MRI to differentiate these clones. Ultimately, we need a radical transformation in how we make decisions to treat prostate cancer. These 20 men here represent a group of men, perhaps in one of our hospitals, diagnosed with prostate cancer a few years back. Well, we've already worked out, haven't we, that the men with low-grade disease, the blue men, don't need treatment. Thankfully, we now put them on active surveillance. But we still have the other 5 with intermediate or high-grade disease. And currently, we treat all 5 of them, whereas perhaps only one of them actually benefits from treatment. And that's a conservative estimate. Some would say 1 in 10, others maybe even 1 in 20 benefit. That is too many men having unnecessary treatment. This is why the 10 and 15-year survival benefits for the patients who we currently treat are in the few percentage points, using, for example, the Predict Prostate algorithm sponsored by NICE in the UK. And of course, we know that these treatments cause harm. In conclusion, we've got to do a better job at selecting those men who actually need treatment and de-escalate the rest. My hope is that next generation risk stratification with liquid biopsies, with novel MRI and with histological AI algorithms will enable us to do this more accurately. Liquid biopsies to check whether CTCs with the potential to establish METs are present. Novel MRI trained to recognize not just Gleason grade group 2 to 5, but regions with MRI features of potential metastasis, whether coexistent or in the future. And morphological AI, models that are designed again, not just to detect cancer, but the cancer that really matters. And actually, although we're talking about a transformation of decision-making in the prostate, we're not actually moving that far from the traditional risk stratification tools that we've been using for many decades. It is, after all, still just a blood test, a scan, and a biopsy. Thank you so much for watching, and I look forward to any questions you may have in the discussion section. Thank you.